My name is Dr. Shreyansh, and I am assistant professor in Department of General Medicine in BKLWRMC Medical College. So I will be talking about the topic ascites today. So let's begin. Yeah. So firstly, we will see the pathogenesis of ascites. So we'll talk about the pathogenesis in two scenarios. First scenario is the pathogenesis in the presence of cirrhosis, and second one is the pathogenesis in the absence of cirrhosis. So, in the presence of cirrhosis, there are several mechanisms which contribute to the accumulation of ascitic fluid. First one is ascites in patients with cirrhosis is the result of portal hypertension and renal salt and water retention. And uh, these are the similar mechanisms which contribute to accumulation of ascites in the for in heart failure. And portal hypertension means, as you all know, portal hypertension means the elevation of portal pressure, the way pressure in the portal vein. So, according to Ohm's law, pressure is the product of resistance and flow. So, when hepatic resistance increases, the pressure increases. And the hepatic resistance can increase due to several mechanisms again. So, first one is development of hepatic fibrosis, which impedes the normal flow through the liver. And second is the activation of the hepatic stellate cells, which leads to smooth muscle contraction and fibrosis. And cirrhosis are associated with a decrease in the endothelial nitric oxide synthase also, which leads to intrahepatic vasoconstriction. So nitric oxide, as you all know, is a vasodilator. So increased systemic circulating levels of nitric oxide lead to increased levels of VEGF and TNF, which results in splanchnic arterial vasodilation. Then vasodilation of the splanchnic circulation causes pooling of blood and decrease in the effective circulating volume, which is perceived by the kidneys as hypovolemia. So the blood reaching the kidneys is reduced due to splanchnic vasodilation. And there is compensatory vasoconstriction, which is occurs due to release of the ADH, antidiuretic uh, hormone, which causes which the hormone in turn causes free water retention. It causes activation of the sympathetic nervous system and activation of the RAS, which leads to sodium and water retention. Now, in the absence of cirrhosis, like uh, in causes like peritoneal carcinomatosis, the tumor cells lining the peritoneum, they will produce a protein-rich fluid, which contributes to the development of ascites. In primary peritoneal malignancies, which are sarcoma and mesothelioma, this can occur. It can occur in abdominal malignancies like gastric or chronic adenocarcinoma, and also metastatic disease from breast or lung carcinoma or melanoma. Fluid from the extracellular space is drawn into the peritoneum, further contributing to the development of ascites in such situations. Then tubercular peritonitis also causes ascites. It is due to a similar mechanisms. So the tubercles which are deposited on the peritoneum, they will exude a proteinaceous fluid into the abdominal cavity. Then pancreatic ascites results from leakage of pancreatic enzymes into the peritoneum. So you can see here, this is a CT of a patient with peritoneal carcinomatosis. The white arrow is showing the peritoneal carcinomatosis, and the yellow arrow here is showing the ascites accumulation. Now we come to causes of ascites. So most common cause of ascites is cirrhosis, and it accounts for 84% of the cases of ascites. Cardiac ascites, peritoneal carcinomatosis, and mixed ascites due to different combination of different pathologies, like cirrhosis along with another pathology. These account for 10 to 15% of the cases. Less common causes are massive hepatic metastasis, infections like tuberculosis and chlamydia, although tuberculosis is quite common in India also. Pancreatitis and renal disease like nephrotic syndrome. All these contribute a lesser portion of ascitic causes of ascites. And rare causes are like hypothyroidism and FMF, which is familial Mediterranean fever, which is more common in the Middle East. So, how do we approach the patients of ascites? So, firstly, we will tap the fluid, the peritoneal fluid, and we will send it for certain investigations. So, this is called paracentesis. So, paracentesis is usually done from the left lower quadrant because this space is more comfortable and has less complications. It is safe even in coagulopathy, and complications which occur less frequently are there can be a development of hematomas, there can be hepatorenal syndrome, hypotension, and infection. So gross appearance of the fluid, firstly, we see the gross appearance of the fluid which has been tapped. So gross appearance, the fluid can be turbid. This results from infection or infiltration by tumor cells. White milky fluid indicates a chylous ascites, in which the triglyceride levels of the fluid are more than 200 milligram per deciliter, and often it is more than 1000 milligram per deciliter. Chylous ascites results from lymphatic disruption, which can occur with trauma, cirrhosis, tumors, tuberculosis, or certain congenital abnormalities. So all these causes are possible when we find a chylous ascites. Dark brown fluid can also be present, which can reflect a high bilirubin concentration, and it indicates a biliary ascites, or that is due to biliary tract perforation. A black fluid can indicate the presence of pancreatic necrosis or metastatic melanoma. Then labs. So what are the labs which you will send? First one is you will measure the albumin in the fluid. Then we measure the total protein levels of the fluid, and we do a total and a differential count within the fluid. So uh, the total count will let us know if there is an infection. So if infection is suspected, gram stain and culture, inoculation into blood culture bottles at the patient bedside to maximize the yield has to be done. Then serum albumin level should be measured simultaneously along with the measurement of fluid albumin so that we can calculate something called SAG. So SAAG, it means serum ascitic albumin gradient. So SAG is very important in diagnosing the cause of ascites. So it helps us distinguish causes of ascites depending on the value of SAG. So the SAG, when the ascites is caused by portal hypertension or non-portal hypertensive causes, we can differentiate that looking at the SAG. It reflects the pressure within the hepatic sinusoids and correlates with the hepatic venous pressure gradient, HVPG, which is actually calculated by catheterization. But the SAG can give us an idea and avoid the catheterization in all patients. So according to Starling's law, a high SAG, what do we mean by high SAG? When SAG is more than 1.1 gram per deciliter. it reflects a oncotic pressure that counterbalances the portal pressure. And if SAG is less than 1.1, it indicates that ascites is not related to the portal hypertension. It is not due to increased pressure in the portal circulation, as in tuberculous peritonitis or peritoneal carcinomatosis or ascites due to pancreatic causes. So another important thing that we have to consider is the ascitic protein level. So ascitic protein level of more than 2.5 indicates that hepatic sinusoids are normal and are allowing the passage of protein uh, into the ascitic fluid. This occurs in cardiac ascites, early Budd-Chiari syndrome, and sinusoidal obstruction syndrome. If the ascitic protein level is less than 2.5 gram per deciliter, it indicates that the hepatic sinusoids have been damaged and scarred and are no longer allowing the passage of protein into the ascitic fluid. This can occur in cirrhosis, then late Budd-Chiari syndrome, and massive liver metastasis. So here we have the flow chart showing how to differentiate. So we have the SAG, first of all, which is divided into SAG more than 1.1 gram per deciliter and less than 1.1 gram per deciliter. So more than equal to 1.1 gram per deciliter, then we will look at the protein levels. If protein levels are less than 2.5 gram per deciliter, then the causes are cirrhosis, a late Budd-Chiari syndrome, and massive liver metastasis, which indicates that the sinusoids are damaged and are not allowing passage of protein into the ascitic fluid. Ascitic protein of more than 2.5 gram per deciliter, along with a high SAG ascites, indicates heart failure or constrictive pericarditis. There can be early Budd-Chiari syndrome. It occurs in IVC obstruction and in sinusoidal obstruction syndromes. Then we come to causes of SAG less than 1.1 gram per deciliter. In this, the causes are biliary leak, nephrotic syndrome, pancreatitis, peritoneal carcinomatosis, and tuberculosis. So further tests are indicated only in specific clinical circumstances. Usually a SAG will help you get an idea of the diagnosis. So when do you do further tests? When secondary peritonitis resulting from a perforated hollow viscus is suspected. Then we do ascitic glucose and LDH levels. Then in contrast to spontaneous bacterial peritonitis, which can complicate cirrhosis, secondary peritonitis is suggested by an ascitic glucose level less than 50 milligram per deciliter, an LDH level higher than the serum LDH level, and detection of multiple pathogens on ascitic fluid culture. When pancreatic ascites is suspected, the amylase level can be measured, which can be more than 1000 milligram per deciliter. Cytology can also be useful in diagnosis of peritoneal carcinomatosis. Tuberculous peritonitis presents with an ascitic fluid lymphocytosis, but it can be difficult to diagnose by paracentesis. Smear for acid-fast bacilli has only sensitivity of 0 to 3%, and culture can increase this sensitivity tenfold, up to 35 to 50%. In patients without cirrhosis, elevated ascitic ADA levels has a sensitivity of more than 90% for tuberculous ascites, when the cutoff value of 30 to 45 units per liter is used. When cause of ascites remains uncertain after all investigation, a laparotomy or laparoscopy is indicated, along with peritoneal biopsies should be done for histology, and culture remains the gold standard for diagnosis of tuberculosis. Treatment. So treatment of ascites, the initial treatment for cirrhotic ascites is restriction of sodium intake to 2 gram per day or lesser than that. So oral diuretics are used typically. The combination of spironolactone and furosemide is used, and this is done to increase the urinary sodium excretion. Spironolactone is an aldosterone antagonist which inhibits sodium resorption in the DCT of the kidney. Use of spironolactone may be limited by hyponatremia, hyperkalemia, or painful gynecomastia. If gynecomastia is distressing, amiloride can be used, which is in a dose of 5 to 40 milligram per day, may be substituted for spironolactone. Furosemide is a loop diuretic that is generally combined with spironolactone in the ratio of 40 to 100. 40 is to 100. Maximal daily doses of spironolactone and furosemide are 400 milligram per day and 160 milligram per day respectively. Fluid intake may be restricted in patients with hyponatremia. So the indication for restriction of fluid in ascites is usually hyponatremia. Refractory cirrhosis is defined as the refractory cirrhosis is commonly encountered in your practice, and it is defined by the persistence of ascites despite sodium restriction and maximal diuretic use, or maximally tolerated diuretic use also. Pharmacologic therapy for refractory ascites includes addition of midodrine, an alpha-1 adrenergic agonist, or clonidine, which is an alpha-2 adrenergic agonist, to diuretic therapy. These agents act as vasoconstrictors, counteracting the splanchnic vasodilation. So midodrine alone or in combination with clonidine improves systemic hemodynamics and control of ascites over that obtained with diuretics alone. Refractory cirrhotic ascites can be managed by either repeated large volume paracentesis, which is called LVP, or a TIPS, which is transjugular intrahepatic peritoneal shunt that decompresses the hepatic sinusoids, or transjugular intrahepatic portosystemic shunt. Intravenous infusion of albumin accompanying large volume paracentesis decreases the risk of post-paracentesis circulatory dysfunction and death. Patients undergoing the large volume paracentesis should receive IV albumin infusions of 6 to 8 gram per liter of ascitic fluid removed. TIPS placement is superior to LVP in reducing reaccumulation of the ascites, but it is associated with increased frequency of hepatic encephalopathy with no difference in the mortality rates. Other techniques are use of the alpha pump system, which consists of an automated pump and tunneled peritoneal catheter that transports ascites from peritoneal cavity to the urinary bladder. This is associated with a higher frequency of technical difficulties and also renal dysfunction. Malignant ascites does not respond to sodium restriction or diuretics. These patients usually require serial large volume paracentesis. They can require transcutaneous drainage catheter placement or creation of a peritoneovenous shunt, a shunt from the abdominal cavity to the vena cava, or placement of the alpha pump system if available. Ascites caused by tuberculous peritonitis is treated with anti-tubercular therapy, and non-cirrhotic ascites of other causes is treated by correction of precipitating conditions. So what are complications of ascites? The first complication is spontaneous bacterial peritonitis. It is common and potentially lethal complication of cirrhotic ascites. SBP occasionally complicates ascites caused by nephrotic syndrome also, and heart failure also that caused by acute hepatitis and acute liver failure, but it is rare in malignant ascites. Patients with SBP generally note an increase in the abdominal girth. However, abdominal tenderness is found only in 40% of the patients. Rebound tenderness is uncommon in these patients. Patients will have fever, nausea, vomiting, or the onset of or new onset or an exacerbation of pre-existing hepatic encephalopathy. In hospitalized patients with ascites, paracentesis within 12 hours of admission reduces mortality because of early detection of SBP. So early detection is the key. SBP is defined as a polymorphonuclear count of more than 250, an absolute polymorphonuclear count of more than 250 per microliter in the ascitic fluid. Cultures of ascitic fluid should be performed in blood culture bottles, and they typically reveal one bacterial pathogen. The presence of multiple pathogens in the setting of an elevated ascitic PMN count suggests a secondary peritonitis rather than a primary bacterial peritonitis from a ruptured viscus or an abscess. Presence of multiple pathogens without a PMN, elevated polymorphonuclear count, it suggests a bowel perforation from paracentesis needle. SBP is generally the result of an enteric bacteria that have translocated across the edematous bowel wall. The most common pathogens which are isolated are gram-negative rods, including E. coli, Klebsiella, and also sometimes streptococci and enterococci can be the cause. Treatment of SBP with an antibiotic such as IV cefotaxime is generally effective against gram-negative and gram-positive aerobes. A 5-day course of treatment is sufficient if the patient improves clinically. Nosocomial or healthcare associated SBP is frequently caused by multi-drug resistant bacteria, and initial antibiotic therapy should be guided by the local bacterial epidemiology. Cirrhotic patients with a history of SBP and ascitic fluid concentration of less than ascitic fluid total protein concentration of less than 1 gram per deciliter or active GI bleeding should receive prophylactic antibiotics to prevent SBP. Oral daily ciprofloxacin is usually used where available, and norfloxacin can also be used. IV ceftriaxone may be used in hospitalized patients. Diuresis increases the activity of ascitic fluid protein opsonins and may decrease the risk of SBP. So, diuresis increases the activity of opsonins, which are antibacterial, and they may decrease the risk of SBP. So, thank you very much. I hope the topic of ascites is clear from this lecture.